let's discuss all the fungal disorders in the nose. All right. So we will discuss all the fungal disorders, starting with the simplest one, that is the fungal ball. Fungal ball, also known as mycetoma. Fungal ball, also known as mycetoma. Most common fungus, Aspergillus fumigatus. So most common is Aspergillus fumigatus. This is also known as Aspergilloma. Aspergilloma. So what is this? What is this? A fungus gets collected in the sinus. Fungus is collected in the sinus. What happens? No invasion. Number one, no invasion, no reaction from the fungus. So what happens because of this? No invasion. Number one, no invasion. Number two, no reaction from the nasal mucosa. Okay, so no reaction from the nasal mucosa. This fungus keeps on growing. This fungus keeps on growing. It accumulates in the sinus cavity, and because of the pressure, it can even destroy the bony wall. It's just a simple collection of fungus in the sinus known as fungal ball or mycetoma. Treatment? Evacuation. Evacuation. Remove the fungal ball. Okay, open up the sinus. To open up the sinus means you do FS and evacuation. You remove the fungus. Problem solved. Nothing else to be given. Patient immune status is normal. Patient is an immunocompetent patient. No immunocompromised problem. Okay, patient does not have any reaction to the fungus. Fungus is trapped inside. So no antifungal required because there is no invasion. Right? No invasion, no antifungal required. Patient is an immunocompetent patient. Right? Just a simple collection of fungus. All right. Now, let's say patient has an allergic reaction. Allergic fungal rhinosinusitis, AFRS. So now patient has a allergic response, type 1 hypersensitivity response to this fungus. That is known as allergic fungal rhinosinusitis. Causative fungus, number 1, bipolaris. Bipolaris. Number 2, curvularia. And number 3, again, Aspergillus fumigatus. Aspergillus fumigatus. Right? Now, before we understand this CT scan, understand the CT scan, let's understand the diagnostic criteria of AFRS. The allergic fungal rhinosinusitis, also known as AFRS, this has a criteria for its diagnosis. We call it as Bent and Kuhn diagnostic criteria. Bent and Kuhn diagnostic criteria. So what is this Bent and Kuhn diagnostic criteria? It consists of major and minor criteria. Okay, it consists of major and minor criteria. So what are the major criteria? Number 1, as I told you, patient is hypersensitivity. Patient is having allergy. So patient is having type 1 hypersensitivity to the fungus. So there is a fungus and patient is allergic to it. So the mucosa will also react now. Right? Patient has type 1 hypersensitivity. This is the major criteria. Remember, type 1 hypersensitivity, allergic patients can also have asthma. Asthma is also a type of type 1 hypersensitivity. So asthma is a minor criteria. It may be present. Whenever we say may be present, it's a minor criteria. Okay. Because of this hypersensitivity, patient can have nasal polyps. There is formation of multiple polyps in the nose. So we will discuss this polyposis in the next topic after the fungal diseases. Okay. So patient can have multiple polyps in the nose. Right? So polyps, again, they show that the patient is having sensitivity, hypersensitivity. Right. Number 3, patient is having characteristic CT scan findings. So what are these characteristic CT scan findings? Let's go back to the CT scan and see these characteristic CT scan findings. So what do you see over here? What are the characteristic CT scan findings? Let's look over here. So characteristic CT scan findings, you can notice that the number one, patient is having a unilateral disease. Disease on the one side, the other side may be normal. Why? See, the allergy is going to be on both the sides. The patient is having allergic mucosa is on both the sides. But generally, the fungus is trapped only on one side. The fungus is trapped only on one side. Okay, generally, not always. So look in the second photograph, you will see that the fungus is on both the sides. So it can be on both the sides also, but generally it is unilateral. So because it can be on both the sides, but generally it is unilateral. So you see, unilateral disease is a minor criteria. Unilateral disease is a minor criteria. So this is the first characteristic CT scan finding. It is generally unilateral, okay, but it can be bilateral. Right? What else is there? What else is there? Now, when we see this, we will notice that you see over here, the bone is eroded. The bone is eroded because of the chronic pressure. Because there is a lot of pressure, it can erode the bone. So bone erosion is present. But if you notice, in spite of bone erosion, in spite of this bone erosion, the fungus has not gone into the orbit and involved the orbit. There is no invasion. There is no invasion into the orbit. The bone is eroded because of pressure. Right? Okay. So you see over here, bone erosion may be present. Bone erosion may be present. Okay. So not necessary, but it can be present. But there should not be any invasion. If there is an invasion, it does not remain allergic. It becomes invasive. So invasion, without invasion, that's a major criteria. Bone erosion is a minor criteria. Invasion is a major criteria. And this invasion, you see, there is no invasion. Patient has allergic discharge. Patient has allergic discharge. This is known as eosinophilic discharge. Patient has eosinophilic discharge. Okay. Anything else in the CT scan findings? What do you see? You see a heterogeneous mass. In between, you see these white patches. These are calcium deposits. We call them as hyperdensities. So in the patient, you have these hyperdensities. These hyperdensities are due to calcium deposits in the dense fungal hyphae. So these are the dense fungal hyphae. There are calcium deposits, and that leads to formation of these hyperdensity. Right? So patient has hyperdensities. It's a heterogeneous mass. This is a characteristic CT scan finding. Right? So because it is allergic discharge, patient has a lot of eosinophilic rich secretions in the nose, and it stains positive for fungus. Patient secretions or the mass inside, it stains positive for the fungus. Right? So these are the major criteria. See, fungal staining is a major criteria, but we don't send all the samples for culture. Culture take a lot of time. Culture may not be positive also because of contaminants. So fungal culture is a minor criteria. Right? Patient is allergic. Patient may have a serum eosinophilia. That is also a minor criteria. Again, there is presence of charcoal, Leyden crystal. Important MCQ question. That is also may be present. So that's a minor criteria. Right? So this is the Bent and Kuhn diagnostic criteria for AFRS. Okay. So treatment. Patient has two problems. What are the two problems? Number one, patient has fungus in the nose. Number two, patient has allergy to the fungus. Patient has allergy to the fungus. So what do you need to do? Number one, treat the fungus, remove the fungus. Okay. Number two, treat the allergy, give steroids. Right? So two things. Allergic fungal rhinosinusitis, two things. Number one, treat the fungus, remove the fungus, do a FES. So treatment is number one, do a FES, remove the fungus. Okay. Number two, steroids. Decrease the allergy. Okay. So how can you decrease the allergy? You can decrease the allergy by giving steroids These steroids are given as nasal steroids, but you can also give a short course of oral steroid over here to decrease the allergy. Right? Okay. Now patient is having a lot of allergic component for the fungus. You may also have to give this patient immunotherapy. Immunotherapy. Okay. So what is immunotherapy? It is increasing doses of allergen given over a period of time to decrease the allergic response of the patient. So this is known as immunotherapy or immune modulation. Right? So this is immunotherapy to decrease the patient response, the patient hypersensitivity response to the allergen. Right? So this may also be required in many cases. So this is the treatment of allergic fungal rhinosinusitis. All right. So we have discussed the fungal ball. That's just a collection of fungus. We have discussed the allergic fungal rhinosinusitis. We have discussed the chronic granulomatous disease, that is the rhinosporidium caused by Rhinosporidium seabury. Okay, so we have discussed the three. Let's come to the invasive fungal disease, that is the rhinocerebral mucormycosis. Rhinocerebral mucormycosis. Now, rhino means nose, cerebral means brain. So, nose, brain, mucor. So, we have the mucor, we have the rhizopus. Right? We have the mucor and we have the rhizopus. So, you see, mucor, rhizopus, these are normal saprophytic fungi. So, what do I mean by saprophytic fungi? These fungi, they live on our body. They feed from the dead epithelial cells, dead tissue, but they do not cause us any harm. Right? So these fungi, they do not cause us any harm. Now, what is the problem in rhinocerebral mucormycosis? In rhinocerebral mucormycosis, we have number one, acute. So short duration disease. Number one, acute. Number two, invasive. Now the fungus invades into the tissue. Okay. Fulminant, rapidly spreading. This is rapidly spreading, fulminant. Fungal disease. Which fungi? Mucor, rhizopus. So we know that these are normal saprophytic fungi. So why are they causing so much of problem? Okay, because the patient is in a immunocompromised patient. Okay, so now the patient is immunocompromised, especially diabetic patients with uncontrolled sugar. Diabetic patients with uncontrolled sugar. Now, why especially diabetic patients? Why diabetic patients? You see, in diabetic patients, there is insulin is less, there is lot of dextrose in the blood, lot of glucose, lot of dextrose. What do we use for fungal culture? Dextrose agar. So what does fungus needs for its growth? Dextrose. There is a lot of dextrose in the blood. Patient is immunocompromised, so the fungus is able to grow nicely. Right? So what happens? This fungus, it invades into the tissue. It goes inside the blood vessel to take the sugar. Right? So when it goes inside the blood vessel, when this fungus goes inside the blood vessel, there is a thrombus formation. Remember, the blood recognizes the fungus as a foreign object and it will form a thrombus around it. Right? So that blood vessel will undergo thrombosis. The area supplied by the blood vessel undergoes ischemia and necrosis. This is known as necrotizing vasculitis. Right? This is known as necrotizing vasculitis. Now, how will this patient of rhinocerebral mucormycosis present? Areas of nose, they are undergoing necrosis. Now, because of necrosis, the nose starts becoming black, the septum starts becoming black, or the palate becomes black, or the terminates become black. Okay, how will the patient present? This presentation is a very late presentation. Normally, this is all inside. From outside, this is not visible. Right? So, how will the patient present? Okay, let's remember the blood supply of the nose. So, the nose is supplied by these 5 arteries. You see, the fungus invade the arteries. They are bringing the blood, they have a sugar, so that it invades the arteries. Let's say it invades the anterior ethmoidal or the posterior ethmoidal artery. Anterior ethmoidal, posterior ethmoidal, they are branches of ophthalmic artery. Okay, they are branches of ophthalmic artery. So this invasion spreads to the ophthalmic artery. Ophthalmic artery is thrombosed. Patient lands up in blindness. Ophthalmic artery supplies retina and optic nerve. So patient lands up in sudden blindness. Okay, this ophthalmic artery, this is a branch of ICA, internal carotid artery. This thrombus breaks. It goes into the ICA. It becomes a thromboemboli. The ICA takes it to the brain. Patient has stroke. Patient has stroke. Okay, rhinocerebral. Rhinocerebral. Now the fungus has gone from the nose to the brain. Rhinocerebral mucormycosis. Right? Okay. So patient presents with these two complaints. Number one, patient has sudden blindness. Number two, patient has stroke. These are the two most common presentations. As you can see, the morbidity is high. Morbidity is high. Now, where is the fungus? Fungus is inside the blood vessel. Okay, you need to kill this fungus. To save the patient, you need to kill the fungus. So, drug of choice now is amphotericin B. The drug of choice is amphotericin B. This is the drug of choice. This is also the treatment of choice. Right? So now drug of choice, treatment of choice is same. That is amphotericin B. Of course, for this disease, you have to control the sugar level. Yes. Okay. We have to also sometimes do surgical debridement. We have to remove the dead necrotic tissue, okay, which has the fungus mass. We have to remove that. But amphotericin B is the mainstay of treatment. This is the life-saving drug over here. Okay, it saves the patient. This is the drug of choice and the treatment of choice. Amphotericin B. Okay, let's look in this CT scan. What do we see? This is a fungus, and now you can see there is not enough pressure. You can see a lot of air pockets here and here, and it has still invaded the orbit. You can see bone erosion is there. Some part of bone is present, but bone erosion is there, and through that it has invaded into the orbit. This is an invasive fungal rhinosinusitis. The erosion is not because of pressure. It is because of invasion, and as you can see, it has gone inside the orbit. So it's an invasive fungal rhinosinusitis, rhinocerebral mucormycosis. Right? Okay. So these were the fungal diseases